Hi everyone, welcome to the Urology Cases podcast. I'm Rowan Kenny. I'm a GP at Cartinol and Door Surgery, and I'm one of the cases GPs for urology. I'm really kindly joined by Mr. Matt Sims. He's a consultant urologist in Hull with a special interest in pelvic cancer and male infertility, working at Castle Hill Hospital. And he's a Sheffield graduate, if any of you recognise his name. So thanks for joining us, Matt. I really appreciate your time.
Nice to be here.
Thanks. We had a quick chat last night, didn't we, about pressing issues for GPs in urology. And the first thing that came up, of course, was PSA and issues around that. But what I might do, if it's okay with you, is if we come to that a bit later on, and we'll just run through a few smaller queries. These are the kind of things that crop up all the time in referrals to urology. And I'd just be interested, a secondary care perspective on some of these problems, if that's okay.
Of course, yeah.
Right, so probably the number one thing that people ask about is the significance of sterile pyuria. We pick this up a lot, often in elderly patients, often unexpected. And on the whole, generally, I think what we're supposed to do is if you get 2 out of 3 samples with sterile pyuria, we should be considering further investigation and referral. But then we get mixed messages from urology. I think there are different approaches to what we should do with this. Could you perhaps give us a heads up on what do you think are the more worrying things we should be looking for in these patients, and should they all be referred?
Well, they don't all need to be referred, but there are certain patients that I think that definitely merit a referral. And I mean, I guess it's a common problem, and you'll see it, as I said, all the time in primary care. Infection is by far and away the most common cause, and of course, sterile pyuria. Sometimes it's not sterile pyuria; it just means that you haven't managed to culture the urine properly. So it's definitely worth. That's always the first thing. Have they got an infection that we haven't managed to diagnose, really? And we all assume that urine culture is 100% sensitive and 100% specific. Of course, it's not, and it can be done badly. And if a urine sample's left sitting around on the side of a surgery for a few days, it's just not going to pick anything up. So the way that is collected is important. Obviously, younger patients less likely to be significant pathology, and in younger patients, certainly in men, STIs are important, and it's not uncommon to present like that. We don't tend to see that in secondary care because it's usually sorted out. I would say that obviously younger women, recurrent infections, etc. But there is some significant pathology that we do pick up from sterile pyuria, particularly in elderly patients. And I'd agree that persisting sterile pyuria in the absence of infection, certainly in the presence of unexplained low urinary tract symptoms, definitely merits further investigation. It's not that unusual when we see, again, squamous cell invasive muscle invasive bladder cancers, particularly squamous cell cancers, can present like this. They're less commonly present with hematuria, and it's much more common. So these are things that tend to present with recurrent infections, particularly in elderly ladies. There's a whole host of rare diagnoses that we don't see, but the urological malignancy can certainly present with sterile pyuria. So, in an elderly patient, yes, by all means, refer them along. They certainly merit further investigation with a cystoscopy and some protracted imaging. And we may not find a cause for it. We may not find a cause for it, and we don't always find a cause for it. But you only find a significant cause if you look for it, basically. So it needs investigating. Certainly for that elderly group, I think it's important, really.
Yeah, it's interesting. We had a urologist speak at the Primary Care Urology Society saying that he reckoned that MSUs, the standard, MC and S that we send off, is somewhere between 60 and 80% accurate.
Yeah, that's right.
And sensitive.
So don't
And
always.
so, yeah, and hence why we often do prescribe antibiotics empirically, because symptoms in women, especially in uncomplicated UTI, are pretty much as accurate as a standard MCNS.
Yeah, and I think that if someone gets better with antibiotics, it's an infection. I mean, that's you almost most of the time anyway. And I think and you know, I think urine dipsticks, I mean they're helpful, but I think it's important to send off an MSU ideally before you start antibiotics. But you know, they're not 100% sensitive and specific, and we know that. And
So actually, I think informally, what probably a lot of GPs do is if they come across sterile pyuria, we hunt around, and if there's even the faintest symptom, we'll treat it as a UTI and then check follow-up specimens, and if they're clear, it's not sterile pyuria, it was a UTI all along. Is that a reasonable start?
I don't think that's unreasonable. I mean, of course, there are non-infective, you know, interstitial cystitis, prostatitis, all these things can also cause infection, but I don't think that's an unreasonable approach to treat it empirically, because it's by far the most common cause of sterile pyuria, and I think that's fine. But you know, just we do see patients, if it persists, the odd patient who has significant underlying pathology that you know, do need referring in, really.
Yeah. Okay.
And TB, of course, is a classic, you know, sterile pyuria thing, but I mean that's very rare. But I have seen a few cases of TB, but it's pretty rare, to be honest. But it's a classic cause of persisting sterile pyuria. Yeah, so just one of those rare things that you see, particularly in Sheffield, in the cities, you might see it more commonly, really. Yeah.
I was going to say exactly that. Yeah, we certainly have some practices that are well used to testing for TB and even schistosomiasis as well. I mean,
absolutely,
more often with non-visible hematuria. But okay, so I think the take-home message there is that we should be quite sort of tenacious with these odd sort of specimens that come back with sterile pyuria, and not dismiss them as, oh, it's okay, it's normal. We should really follow through, consider treating for UTI or other treatable infections like STIs. And if they truly do persist with sterile pyuria after all reasonable initial interventions, these patients are going to need referral onto urology for potentially for cystoscopy and imaging.
I think that's
notwithstanding all those things
that's a pretty good summary of what we've said, I think.
Yeah, brilliant, thank you. On to something that is altogether more alarming for the patient, at least, and it's alarming for me when patients send us a photograph of this next symptom, which increasingly in the digital world, you know, patients can send us pictures of anything. So hematospermia, we often get very anxious men reporting evidence of blood in the urine, anything from a couple of specks to kind of reasonable sized clots. And again, the message from, you know, when you look online for guidelines or from specialists, can be a bit mixed. We understand that in younger men, isolated episodes are pretty low risk and usually don't need investigating. Do you have a threshold at which you would say, oh, we really need to see these guys?
So, and again, you know, it's to do with age again. So the older a patient is, the more likely there's going to be significant pathology. And yes, we see every year we'll see patients with prostate cancer presenting with hematospermia and no other symptoms really. So yes, younger guys, a single episode, it's self-limiting, and those guys just need, they need examining. They need to have a urine dipstick to make sure there's no hematuria. That's important, of course. But most of these patients, you won't find anything at all, and a one-off episode can be reassured. But again, the older the patient is, the more likely there is to be pathology there. So doing a PR, checking the PSA once things have settled down, again, excluding infection, prostatitis, etc., can can if you can exclude prostatitis,
Yeah.
and we might talk about that later on, I guess. But yeah, these are things that need a bit of thought. But again, the presence or absence of hematuria, non-visible hematuria, that would warrant referral into secondary care. So yes, I mean, and recurrent non-explained hematospermia, yes, it needs investigating, and we would do all these things. If they haven't been done in primary care, we would repeat those in secondary care. We would do a cystoscopy if there was any hematuria, and for patients with unexplained persistent hematospermia, certainly in elderly blokes, I would tend to get an MRI scan just to make sure that there's no evidence of that's, and sometimes you do pick up. It's reassuring sometimes because you might see blood products in the seminal vesicles and no other cause for it, and I think you can reassure the patient then. And you do get these patients who come back and forwards we don't find a cause for it, but prostate cancer can present with hematospermia. So yes, rarely, for the vast majority of patients, it's self-limiting. They can be reassured, but there is this small cohort of patients who need a bit of thought. And again, it's the older the patient is, the more likely are they to have significant pathology, like most things, really.
Yeah, that's great. That's really helpful. Thanks, Matt. On the subject of prostatitis, and I realise this is a giant black hole that we could go down with prostatitis. As GPs, we don't often see those really severe, acute septic type prostatitis that maybe you're used to dealing with in secondary care. I guess we do occasionally. We probably see more of the non-specific pelvic discomfort in men, usually in men who've had it before. We have a small cohort of men who seem to get it repeatedly. Routinely, we'll do an MSU, an STI screen, assess the prostate. Usually these findings are normal, and they end up on 2, 4, sometimes even 6 weeks of like ofloxacin, Cipro. And this kind of practice has been brought into focus a bit by the recent guidelines from MHRA saying be careful with quinolones. Are you seeing any increase in people with prostatitis or recurrent prostatitis being referred to you or coming in acutely?
Not particularly. I mean, I think so. Acute prostatitis that you're talking about. So a patient with with a very swollen, tender prostate with a high temperature, with all that and abscess is actually pretty rare. So we don't see it very often, and we might get 1 or 2 cases a year. So that's your rare diagnosis.
That's very reassuring for us as GPs, because I think we go looking for it. We suspect it far more often.
And it's pretty obvious when someone's got. I mean, if you examine someone, they've got a boggy, tender prostate, and they are acutely unwell, and they're septic. Often these patients are. Of course, we all see patients with non-explained chronic pelvic pain, I guess, rather than prostatitis, we call it. And we see lots of patients, and yes, obviously the first thing to do is exclude significant pathology. So do a PR, check the urine dipstick, treat any infection, etc., etc. But in most of these patients, you won't find anything amiss at all. And you're absolutely right. A lot of these patients will have had episodes like this before. And what I tend to do, and we see these patients who have repeated courses of antibiotics, and it's a natural history of chronic pelvic pain, prostatitis. It waxes and wanes, and it tends to come on at certain times. Certainly when patients are stressed, obviously that's something it's much more common. And dealing with those factors tends to help patients as well. But most patients just want reassurance. I think when someone presents with new onset chronic pelvic pain and they've got symptoms which are typical of prostatitis, then I don't think it's unreasonable to treat those patients with a course of antibiotics. And 50% of patients will get better, and that's great. And 50% of patients won't be any better. But it's perfectly reasonable to treat, I think, with a course of empirical antibiotics. But then, if they don't work, don't give them again. Don't carry on repeating lots and lots of courses of antibiotics. And yes, I mean, we've tended to we used to dole out ciprofloxacin quite a lot for these patients, and it's more commonly we recognise these kind of neuropsychiatric side effects, and of course there's this rare risk of Achilles tendon rupture as well. It's about 1 in 900 patients that you see. So what I tend to use now as first line is cotrimoxazole, and that takes a little bit longer to get into the prostate, so 960 milligrams BD for about 6 weeks or so. And if they haven't got any better with that, then don't give them any more antibiotics. Most of these patients will, I mean, again, think about their symptoms. If they've got symptoms of bladder outlet obstruction, that alpha blockers can be helpful. Non-steroidals can be helpful. Simple things to help patients manage, taking hot baths and things like that, and reassurance is what patients need, and it usually sorts itself out. And I usually have a conversation with patients about pelvic floor exercises, and then pelvic floor relaxation, which is actually quite helpful. And most of these patients haven't got prostatitis; they've got abnormalities of their pelvic floor. And actually, if you can signpost them to the right website, or even a physiotherapy, if you're lucky enough to have a physiotherapy with interest in chronic pelvic pain, that can be very helpful actually. And occasionally you do see these guys who come in with quite severe pelvic pain, and when you examine them on PR, they've got a specific trigger spot which is tender, and those are patients that tend to do quite well with proper dedicated pelvic floor physiotherapy. With more diffuse kind of pains, if they understand what's going on, they're reassured they haven't got pathology, and you give them some advice, then it's quite good. There's also a little bit, again, this is a bit airy-fairy, but I often talk to patients about pollen extracts and stuff like that. And again, there is some level 1 evidence that can be helpful for patients with chronic pelvic pain. So again, if patients think they're doing something and you're being proactive, then usually, I'm sure there's a placebo effect with these things, but it will get better, and that's what happens really. So most of these patients just need reassurance, and they tend to improve really.
That's really helpful. It's interesting to hear that you're prescribing less and less of the Cipro type drugs, because that feels like the right direction of travel for us as well. And I think, to be honest, it would be really good if Pain Clinic had a pelvic, chronic pelvic pain for men sort of strand to their work. I don't think they do in Sheffield, but some of the referrals I see, I wonder if you can see the GP's done everything, and you just think, I wonder if you're better off with a Pain Clinic referral than a urology outpatients referral.
You do get, most patients will get better, but you do get the odd patient who you just cannot help, and they're very difficult patients to manage really. And in the past, people who are P's and stuff like that was just awful, things like that back in the day. But Pain Clinic, amitriptyline, all these things, it's worthwhile trying them. But some gentlemen, it's very, very difficult to help them, to be honest.
Okay, that's great, thanks. Interestingly, you mentioned the 50% resolution rate. I'm always, as a GP, interested in stuff that gets better by itself without any intervention. And along similar lines, I've just been reading on Peyronie's disease recently, and that's got quite a high spontaneous resolution rate, I believe, anything up to, and please correct me if I'm wrong, but I've been reading stats up to 60% of cases will resolve themselves over time, perhaps not 100% straight, but with a very minor angulation and no subsequent ED. And I must admit, this is one of the really common referrals we get as the sort of interim GPs, where we're giving advice back. They tend to be along the lines of, this man's had a painful lump causing a deviation in his erection. It's been 2 months now, and he'd really like to see someone. So I guess my understanding is that the first 3 months at least, you would expect a painful developing process. And then the guidelines that I've read seem to have changed from advising that things need to be stable for at least 6 months, and some are now saying 12 months before a urologist would get involved. What's your kind of experience of dealing with Peyronie's referrals. I guess it may not be your speciality, but
Yeah, no,
I
I still see Peyronie's and treat and operate on patients with Peyronie's disease. So rarely, most patients don't need anything. But yeah, you're absolutely right. We get a lot of patients who, I mean, it tends to come on quite suddenly, Peyronie's. It's not a gradual thing. And most patients will actually say, gosh, it suddenly happened. And for a lot of gentlemen, it's quite alarming to see that. So, what the hell's going on? And so they'll go and see their GP. And actually, I think most GPs are happy to reassure patients, and the findings are fairly classical. Often get a dorsal plaque or a hard plaque on the dorsal aspects of the penis. And once patients understand what's going on and understand the natural history of the disease, then they're usually reassured. And so the natural history of Peyronie's, it has this kind of acute phase which can last usually somewhere between 6 to 12 months. And during that time, patients will get painful erections, and then the pain and the inflammation tends to settle down, and you're left with a deformity. And during that time, there may be some resolution of the Peyronie's. I mean, we always say it's about 20% or so, but again, it depends on what your definition of resolution is, and for most patients, if at the end of that time they've got a slight deformity of the penis and they can achieve intercourse, then that's fine. That's that. It doesn't need any further treatment. During the acute phase, there's not a lot you can do. I mean, there's a bit of evidence that vitamin E can be helpful. It doesn't make any difference to natural history, but there is some evidence from a randomized study that it can improve pain. And people have tried all sorts of Petaba, colchicine. None of those seem to work, basically. So I tend to recommend vitamin E, because again, it's cheap, it's safe, and again, it's patients I feel like you actually they're being treated for it, which I think is good for them, really. So that sounds very patronising, doesn't it? But it's beneficial to.
It makes perfect sense. Yeah, absolutely. Is that? Can I ask you? Sorry, is that an over-the-counter vitamin E, or is there a specific dose?
Yeah, I tend to go get some vitamin E from Boots. I'm not sure whether that's completely right, and I think I suspect if you look at the study, there's a prescribed dose, but it's not going to change it. It may help with pain, basically. That's what I've tended to do. The other thing that might be that, again, there's a bit of evidence for now is, it's not recent, is using vacuum tumescence pumps, or and I often signpost patients to a company called iMedicare, and iMedicare, and they've got an array of quite well designed vacuum pumps with helpful instructions for patients. Again, one of the issues for Peyronie's for a lot of patients is they lose a lot of length, or a little bit of length of their erect penis, even without surgery. And there is some evidence that using a vacuum pump regularly can help maintain that penile length, and it can reduce the degree of deformity in the long term. So again, it's something that it's empowering patients to treat themselves, really. But at the end of that kind of 12 to 18 month period, and it may be as long as 18 months, if patients are left with a deformity which is preventing them from having intercourse, then that is when they may need to see a urologist, and that's when surgery may be indicated. And the type of operation will depend on the degree of erectile dysfunction, the degree of deformity, local services, etc., etc. But it's a minority of patients who require intervention, really.
Right, brilliant. And is some men get kind of distal ED, don't they? Distal to the plaque.
Yes.
And am I right in thinking that so inability to have intercourse or distal ED are both indications for consideration of surgery?
Again, distal ED is, I mean, there are an array of operations for Peyronie's disease, and the classic one is the Nesbitt's procedure or application. And for some patients, that's not an appropriate operation. So some patients certainly with distal ED, or what's called an hourglass deformity, as well, or a very severe degree of curvature, then it's the wrong operation to do. And for patients with ED and Peyronie's disease, then actually what is probably better for a lot of these patients is an inflatable penile prosthesis, which again, it's done rarely, but it's if you do the wrong operation in someone with Crohn's disease, you'll have a very, very unhappy patient.
Yes, I can imagine. Yeah. And I think that's sometimes what I try and reflect as well is that, if you're going to refer a man with Peyronie's, this man's got to be quite clear that, if he fulfills the criteria for surgery, that surgery is no minor undertaking.
No, that's right. And I always tell patients, this operation is designed purely to give you a straight penis. It's not going to give you the penis you had when you're 18 years old. It's and it's going to be a bit shorter maybe, and there's all these risks.
Yeah.
So surgery is best avoided for the vast majority of patients. And if someone can achieve intercourse, with a bit of curvature, then that's absolutely the right thing to. Then I wouldn't recommend any kind of surgery for those patients. Yeah.
Fantastic, thanks. Just while we were chatting, I had a quick look. The only advice I can find about doses is 400 to 800 IUs of vitamin E daily. It seems to be.
I don't know what Boots kind of vitamin E dose is really. But
I suspect 400 to 800 micrograms or IUs. Yeah, I imagine. Yeah, excellent. Okay, so just one more quick thing before we talk about PSA, and that's just about tight foreskins. I realise none of this is kind of life and death stuff, but it's the kind of thing that gets referred really frequently. And I often get GPs saying, "Oh, I've tried a bit of hydrocortisone, or I've tried a bit of this or that." And I think there's a great deal of uncertainty about whether there's any value in that, or what kind of. Should we only be using steroids where there's clear evidence of something like lichen sclerosis, BXO, whatever? And what's your experience?
So I think when you're talking about phimosis and circumcisions, then I guess we talk about pathological phimosis and kind of physiological, well, not necessarily physiological phimosis, but a non-pathological phimosis. And the pathological phimosis is basically due to BXO. So it's fairly characteristic. Most people are happy to recognise BXO, and I think for early BXO, it is not unreasonable to try a short 6-week course of Betnovate because some patients will improve. And it doesn't work in everybody, but there's no harm in trying that because circumcision can be. There are patients who regret having circumcisions. There are downsides to circumcisions. So I think if you haven't tried conservative management or at least thought about it, then actually, you could have, again, an unhappy patient on board. So it's definitely worth talking about to patients. If someone's got severe BXO and a kind of hard foreskin that's unretractile, there's no point doing, so it depends on the degree of BXO. In patients with inflammatory conditions of the foreskin, so balanitis, I tend to give patients a bit of Trimovate first rather than BXO, and it can help quite a lot of patients. So I don't think it's unreasonable to try steroids in selected patients on a short course, but if you don't, they may not work, but it's worthwhile trying. And clearly, someone who's got a pinhole meatus, again, it's never going to work. They're always going to need an operation, really. So it's difficult to be too. I guess you've got to use your judgment, and it's not unreasonable. So I would not say don't try steroids. I think there is a role for steroids in selected patients, really. Yeah.
Selected patients. Yeah, that's great. I was just thinking, the ones that the most commonly referred ones tend to be the younger men who have just become sexually active and have never been able to draw the foreskin back. And then we get some older men who are reported to have very tight, scarred-looking foreskins,
and those,
both of which are groups that are probably going to go straight through for surgery.
Yeah, and I don't think if you don't think there's any chance of it, loosening or softening it a bit, circumcision, and that's fine. Yeah.
Right. Great. Okay. Thanks. We've probably exhausted more than most people's attention span by chatting for about half an hour already. But I think it's always worth just finishing off on PSA because it probably is the number one urological discussion that GPs have with with men.
Yeah.
And of course, the promise and what's the other one, the precision study recently, I think most people have heard about now, and they understand that there's been this sea change really over the last 5 years. I know Baus would say people should have been doing it for the last 10, 15 years, but about the value of PSA in younger men and the value of PSA potentially as a well, I will talk about screening in a second, but the validity of doing a PSA for men who just want to check if they've got prostate cancer or if they're at higher risk, because the interventions and the investigations are now so much more accurate, and gone are the days of the kind of the trust with the 12 biopsies and the sepsis and all of that sort of thing. And can I ask quickly, so a transperineal biopsy, and I'm saying this as a man of a certain age who's maybe considering this kind of thing might come my way at some point in the future. It strikes me as potentially more traumatic and more prone, making you more prone to adverse effects than a transrectal biopsy. But I guess, is it just because you avoid going through the rectal wall that you get less infection and less sepsis and serious complications?
So trust biopsies should not be taking place anymore at all. Yeah. So that so again, antibiotic resistance, over the last, so we stopped doing trust biopsies about 4 or 5 years ago, and before that, our rate of sepsis was almost 6% with a trust biopsy. So it was that high, and it's that was reflected in a lot of departments across the UK, antibiotic resistance. So you cannot justify doing a trust biopsy anymore. And actually, yes, a lot of people are reluctant to do local anaesthetic transperineal biopsies, but people have tried it before with a kind of brachytherapy template. So you had a kind of fixed template, and you had a kind of almost like a battleship's grid. So it was a lot more uncomfortable for patients doing it in the local anaesthetic. But what's changed things are these freehand biopsy probe, which makes the whole procedure a lot more comfortable for the patient. So you can adequately anaesthetize the apex of the prostate and the pelvic floor. And with most gentlemen, it's a very well tolerated procedure, and there's no doubt that the risk of sepsis is nowhere near what it was. We don't give antibiotics now for our biopsies because we're not going. So we just prep the skin with iodine, and we've done. We have a really good service run by our radiographers actually. So they run the service completely, and they're fantastic at it. And I can remember, the sepsis or the infection rate is way less than 1%, and so there's slightly higher risk of retention with transperineal biopsies compared to a trust biopsy, but it's a much safer and it's a better procedure. And one of the other advantages of it is actually a much more accurate way of biopsying the prostate. So the anterior zone of the prostate was always difficult to get at with a transrectal approach, whereas the anterior zone is actually very straightforward to hit in most patients with the transperineal approach. And about 15% of prostate cancers are anterior cancers. So again, it's a much better technique. But of course, we only do biopsies these days in patients who've had an abnormal MRI scan, and as you say, that's been a big game changer. And of course, I think in the past there has been a reluctance to offer men PSA tests because the knee-jerk 15 years ago, you've got to raise PSA, you need a prostate biopsy, and of course that's not the most. It's a pretty undignified, uncomfortable test to have done. There is a risk of sepsis, and most importantly, there is a high risk of diagnosing clinically insignificant prostate cancer. So MRI scans, you're much less likely to need a biopsy, and you're much less likely to be picked up with clinically insignificant prostate cancer. So that's a game changer, and I think has made the PSA test a much more acceptable test for patients, and I guess that's the main message really. And so this old, oh no, don't have a PSA test, it's going to open up a can of worms. That shouldn't be. And for men over the age of 50, if they want a PSA test, there shouldn't be any barriers for them having that test. And certainly for patients with a family history, black men as well, and of course anybody with BRCA2 abnormalities or genetic predisposition, gives you a predisposition to prostate cancer or aggressive prostate cancer, they should probably be actively given a PSA test probably from the age of 45 or so. Really, that's what should be happening, I think, really.
Yeah, excellent, thank you. Yeah, and the kind of switch between going from a flat rate of anyone with a PSA of 3 in Sheffield, but for several years recently was referred on the 2-week wait pathway, and then we've reverted to the age-related thresholds. And you were saying that may change again in the future, is that right? Because there were some men being missed.
I'm not quite sure, but I think the kind of NICE guidance, the latest NICE guidance or 2-week wait guidance came in, I think about 3 or 4 years ago. I think it's 2021, and it changed from this kind of this blanket PSA more than 3 in patients between 50 to 70. They need referring to these age-specific ranges. So now, if you're between 50 and 60, the 2-week wait referral is recommended for patients with a PSA of 3 or 3.5 or more. For those between 60 and 70, it's 4.5. And for me, that represents a backward step. And I'm not quite sure where those levels have come from, but specifically those levels are for patients who have symptoms, basically. And of course, most of the patients who are seeking a PSA test will not have symptoms, and how do you define symptoms as well? What's that the other thing? Most guys in their 50s will have some kind of urinary tract symptoms. So it's open to it's going to creates a lot of confusion, I think. And I mean, you shouldn't really be advising GPs to go against NICE guidance, but certainly I've advised the GPs locally in Hull to stick with the PSA of 3 cutoff. And we know that some departments have looked, and big departments in London that actually looked at how that would affect, or retrospectively looked in how those new NICE guidance would affect their prostate cancer diagnoses. And they found that they probably missed about 15 or 20% of clinically significant cancers if you applied those guidance. So I don't think it's helpful to have 2 separate PSA ranges for symptomatic and for symptomatic, because simply we don't know what does that mean. And I would say it's much more sensible to stick with the PSA of 3. And the rest of the world is actually using there are lots of countries that use a PSA of 2.5 for a lot of patients as well. We know that probably 10, 15, maybe even 10 or 15% of patients with quite significant prostate cancers, we see it all the time, have a PSA which is less than 3. So a PSA, again, I think it's really important to do a PR as well, because you will pick up disease in patients with a normal PSA, and of course those patients need referring in. But my own personal view, this is my personal view, is that the cutoff of 3.5 for guys between 50 and 60, and 4.5 to 60 or 70 is a backward step. But they are my personal views. Yeah.
No, that's fine. Yeah, no, you won't be held to account over that. It is interesting, this concept of symptomatic versus asymptomatic, and also the concept that early prostate cancer presents with symptoms. Again,
well, it doesn't.
Please correct me if I'm wrong. Well, exactly. I was going to say you're no more likely to have lower urinary tract symptoms with or without early prostate cancer. And this is what we're talking about.
It doesn't make any logical sense to me to do that. So I don't think it's the right thing. And of course, so it comes back to this thing. We now have a non-invasive test which has a 90 to 95% chance of picking up clinically significant prostate cancers. So and we should be encouraging these men to come forward. You know, that's the only way you can make a difference to them. And, you know,
Absolutely.
I get a slightly warped view in secondary care, because I see, you know, loads of guys each week with prostate cancer, where you'll be seeing a lot less than I am, but I see loads of guys who with no symptoms whatsoever, PSAs of 3.1, with quite significant prostate cancer, and you know, the earlier you detect that, the better. Again, this is anecdotal and doesn't mean that screenings are not necessarily the right thing to do, and we don't know the right screening test. But screening will come in for prostate cancer, I'm sure. When it comes in, I don't know, but it may take 10 years or so. But there will be I'm pretty sure there will be a national screening program for prostate cancer, and primary care is going to be a big part of that, I think, aren't they? I suspect.
Yeah. I think one way that, as an interim measure, GPs can kind of get ahead of this is by, if you're prepared to offer PSAs to anyone who asks for it above 50 or above 45 in the high risk groups, then it means that when maybe over a period of time, when they come back for their second, their third, their fourth PSA, you've got something to compare it to. So a live example happened to me two weeks ago. A man whose PSA went from 1.5 because he'd been proactive about getting it checked to 3, and he was still under the age-specific threshold. But we referred him in, and the Sheffield, urologist picked up, and he's got prostate cancer, and he's hopefully heading towards curative treatment. So I think, although this whole situation is fraught with pitfalls, I think the answer is more PSA testing will help, because even if we can't be sure about picking up those men with normal or low PSAs who've got early prostate cancer, what we will see is interval changes and trends, which might push the referral quicker than it would have done if you only do the PSA for the first time when the man comes with, new or evolving symptoms. So I'd encourage everyone to, if you've got men who haven't had a PSA by the age of 60, I would suggest offer them all, as part of their annual review, a PSA at 60. Because again, please correct me if I'm wrong, but wasn't there a big European study that showed that the vast proportion of those men at 60, or something like 70% of men, if their PSA is over 2 at 60, you're much more likely, clinically significant prostate cancer is more likely to come from that group by quite a significant margin than if your PSA is less than 1 at 60.
Yeah, that's absolutely
then
right.
That could inform your decision on how frequently you get your PSA done.
Yeah, that's absolutely, and yeah. So if your PSA is less than 1 at the age of 60, your chance of dying from prostate cancer are less than 0.1% or something like that. So the lower the PSA is, even at the age of 50, the lower your PSA is, the less likely you are to die with prostate cancer. So there are more intelligent ways that we can use PSA, and certainly doing regular PSAs, looking at PSA trends is important. But actually checking someone's PSA at the age of 50, you can actually stratify them into higher or lower risk groups. So someone whose PSA is less than 1 at the age of 50, actually their chance of dying from prostate cancer are going to be much less than someone whose PSA is 3. So someone who's or 2 or whatever. So the patient whose PSA is 2, you might want to check their PSA in a year's time, but someone whose PSA is at 0.89 at the age of 50, say fine, leave it for 3 or 4 years. And so we can use PSA a lot more effectively using this kind of stratified screening, if you like, rather than doing a blanket approach and everybody getting a PSA at a certain time frame. I mean, PSA has had a lot of bad press in the past, but it's a good test. It's the best thing we've got at the moment. If there is going to be a screening program, which I think there will, what tests are we going to use? Well, actually, there's talk of using MRI scan for screening. I don't know how realistic that is. Maybe with AI for reading scans, it might be a realistic proposition. And of course, we know there's patients with high kind of polygenic risk scores and genetic predisposition. Those patients, that may be another way of picking out patients with prostate cancer. There's a big prostate cancer UK are just embarking on a big study of screening. And I think that, they're putting millions of pounds into this big nationwide study, trying to work out what is the best test for screening across for men with prostate cancer. We know PSA testing can reduce prostate cancer mortality by about 20%, but one of the downsides is over treatment. But the European screening study, which is a lot of the evidence has come from that, it didn't rely on MRI scanning. So things move on with prostate cancer, and the problem with prostate cancer trials is that everything takes 10 or 15 years before you get any results. And of course, the world's moved on before that. So MRI scanning may well have a role in a screening program, but quite how it's used, whether everybody gets an MRI scan or whether selected patients do, we just don't know. But there's no doubt we can be a lot more intelligent about the way we use PSA testing. And I would advocate having a PSA at 50 and then seeing where you are at that point, and why would you not be proactive? Why would you not want to do it?
Yeah, with all this evidence that's knocking about, again, I keep mentioning the Primary Care Urology Society. If there are any GPs listening who've got an interest, they're fantastic. They do an annual conference down in London and then get some very esteemed speakers. I'm sure it's only a matter of time before you get invited down there, Matt.
Who knows? I'm waiting with bated breath, Rowan. That's right.
But this guy, I can't remember who it was going as far as saying, we should think about prostate cancer potentially as a chronic disease. And if you die of prostate cancer, because you haven't been tested or you haven't been proactive about checking your PSA, and that's a failure. And obviously there are cases that can come out of the blue and be super aggressive and all of that, but it really is a change from people of our age, what we were taught as junior doctors, to how things are now is quite different. And for all the younger GPs out there who've never been averse to doing the PSAs, then I apologise for us going on like this, but it's one of those things that's been an about face, which doesn't happen that often in medicine, but this is a clear case, isn't it?
I think over treatment has also been a big issue for patients with prostate cancer diagnosis, and again, I think we're much better at not doing that. We're good at counselling patients about active surveillance. We're not diagnosing as much low-risk prostate cancer because we're simply not biopsying patients, and we're only going to get better at predicting the natural history of prostate cancer. So, genetic profiling, all these things are going to help massively. So, all these concerns that doctors and even patients have had about overtreatment, I think they will be less of an issue in the years to come, really. So yes, we should be encouraging men to have PSA testing. Yeah.
Fantastic. Matt, that's been really helpful, and it's always I always learn new things when I'm chatting to you. Not all of them about urology, but
That's right.
on this occasion, no, it's been really helpful, and thank you so much. And
it's a pleasure.
There's an appetite out there for finding out more about this kind of stuff. So I'm sure you've answered a lot of people's questions.
Yeah, I hope it's been useful, and yeah.
Brilliant. Thanks a lot, Matt.
All right.
Thank you for listening, and we'll hopefully there might be another one of these in a year or so, with some new developments. Who knows? Thanks very much.
Rowan. Thank you very
Cheers,
much.
Matt.